Great pleasure to be here. Can we have the slides? Do I click myself? All right. Okay, so thank you so much for the invitation, Andrea. It's really a great pleasure to be here today. So my lab focuses on understanding the molecular basis of aging, trying to understand what is driving the phenotypes that we see in age. Why do we develop features with age? This video is going a little bit slower than usual. Maybe it was the transfer, but we will see that this individual is developing, for example, graying of hair. There will be facial wrinkles, changes in pigmentation in the skin, and many other features that occur with age. So our face is actually quite strong predictor of biological age. We heard from Lear that DNA methylation is a great biomarker of aging, but our face is actually also really a good biomarker of aging. And so this is a unpublished work where we actually basically just looked at facial photographs and looked at this in a clinical setting. And so we collaborated with a hospital in Denmark and looked at 27,000 photos that were taken upon admission to the ER. And then we could do two things because we had follow-up data for, I think, around 8 years. We could look at mortality, if we could predict, so train an algorithm on mortality, basically. And we can also train an age predictor. So the age predictor is relatively good. It's actually on par with the DNA methylation age predictor that we heard Nia talk about. But the mortality is really quite dramatic, I would say. So this is the survival rate, the survival probability, survival curves of individuals in different risk quartiles. And you can see there's a huge difference. And we can combine this with standard triage. So this is a way of determining what shall we do with the patient. Is this patient immediately dying? So you have algorithms for that. And the algorithms are relatively good, but the face, just the facial photograph is actually much better. But if you combine it, you get a 30-day survival hazard ratio of 60. So it's really dramatic what you can get for something like this. And this graph over here describes the concordance index, which is a measure of how good can you predict survival. And it's missing here. This is vitals, basically just pulse, blood pressure, saturation, and so forth. And these are the blood samples that are taken upon enrollment. This is the facial photograph alone, so it's much better than any sample that's taken routinely. And if you combine it, you get a little bit more than just the facial photograph alone. So our face really is really a kind of a gateway to our health. But there are many other features associated with aging. These are a list of different features that we basically downloaded PubMed, which is a biomedical database of literature. And then we looked at what are the phenotypes associated with aging. This is the lifetime prevalence. So the most prevalent feature is graying of hair. Almost everybody gets that. Then muscle weakness is very prevalent as well. There are other things that are much more serious, right? So cancer is very, occurs in about 40% of everybody. And this is just kind of a small snapshot. So aging is really very, very complex. And so we try to look deeper into phenotypes, looking at healthcare records. And this is one of the oldest healthcare records that we know. This is, as you can all see, it's a study on fractures and tumors in ancient Egypt. I'm told, okay, I don't know actually. But we also have healthcare records in Denmark. And so we looked at 33 million pathology reports. So this is basically what the pathologist sees in his microscope, writes down, and then we can analyze features of aging. And you can look at different, basically in this study, we just looked at different terms. And because we have the date of birth and the date of death for individuals, we can look at features of aging, basically based on these this kind of giant spreadsheet in a way. And so this is just doing a principal component analysis on age-aggregated data. So this is age 0, this is age 100. And you can see that, that this really is a very strong sort of aging trajectory. And we can also see these kind of waves of aging that we heard before, or waves of change. So here, this is likely developmental. We can see there's a very strong change in development during development until you're around 20. And then there's another peak change around midlife, around 50. And then late life, there's a very even stronger change. Because we saw this effect on around 50, we're thinking maybe this is menopause related. So we split it up into males and females. And here we can see the females have a very strong developmental change. And then around age 19, then you start kind of changing along this principal component 2 axis, suggesting that this is really the aging process that's occurring here. In males, it's a little bit different. Males are apparently very simple creatures, but it's kind of more, so if you look at the changes in principal components down here by age, you can see nothing much happens actually until you're around 40. In principal component 2, a little bit is happening, but then it's stable around 40, and then it really goes downhill. So it's like the principal component 1 and 2 both describes aging, and it's very, very strong. It's more than 70% of the entire variance of the data set is really just explained by aging. Whereas for females, it's a smaller proportion, but it starts a little bit earlier. So I guess good news or bad news for both sexes. We can also look at specific aging in different tissues, and because we have the date of death, we can also assign sort of hazard ratios for individual terms. And we can also look then at clusters of terms, and then we were thinking about how can we use this, for example, to find interventions. And so we look at clusters of terms. This is a particular cluster of terms that are associated with long aging. And we can then take these terms and go into a different space and then identify each dot here is a molecule. We can identify molecules that are associated with this long aging term. And then we can test these molecules. So one of them we found was nintedanib, and we can see that it reduces predicted senescence. I'm getting back to that in a minute. And then we also did some work in tissues in cell culture, seeing that we're changing things that are probably involved in long aging. And it actually extends the lifespan, and this is in fruit flies. And so this is was just accepted it's in NPJ aging, and you can go to this website to actually explore sort of the data. And so we can also find, we can use other ways, other phenotypes of aging. And so here, for instance, we're looking at tissues. This is also unpublished work. Here we have looked at around 5,000 histological tissues from the Komen Tissue Bank at the University of Indiana. And we can also do an age predictor and get a relatively good age prediction of 5.6 based simply on H&E stained histology images. And this is kind of how it looks. And we can do attention maps, and we see that a large part of what's driving the prediction is changes in the epithelium in the tissues. And we can also associate this with different diseases. So for example, if you have kidney disease, liver disease, or diabetes, you're generally being predicted to have accelerated tissue aging. But you can also actually predict future disease. Again, diabetes is a relatively strong signal here, suggesting that accelerated aging can drive sort of these processes. So we've also looked into different ways of quantifying phenotypes of aging, and one of them is looking at senescent cells. So these are cells that have stopped dividing. They change morphology, and then they secrete inflammatory cytokines. So there's a lot of work suggesting that these cells are involved in in this pro-inflammatory environment that occurs as we age. And so one way that we have attempted to identify these cells is using computational approaches, neural networks we have a neural network that identify nuclei. This is skin fibroblasts in culture. And then we can train on different types of senescence induction using neural networks, and it's very, very, actually quite precise, AUC of 0.99, so this is like a crazy ROC curve. And it correlates relatively well with known markers of senescence, P16, P21, P53. And you can do different types of normalization and still maintain a signal, which suggests that maybe we can implement this in other tissues. And so we've done this also in histology tissues, where we can identify senescent or non-senescent nuclei in different compartments. We can look at spatial segregation, so how do one senescent cell interact with another senescent cell? And interestingly, and this is somewhat known, that senescent cells can induce senescence in neighboring cells. So if you have a cell that's predicted to be highly senescent, then cells immediately surrounding it will also have increased predicted senescence. And what's interesting is that if you have a little, not so much senescent, then your cells around also seems to be less senescent. So this is interesting, but is it actually relevant for anything? And so we have then used the predictor on this large data set where we segment different tissues, and then we can look at how do these signals predict senescence in the future, or disease in the future. And here we focused on breast cancer. These are breast biopsies from healthy women. And when we combine it with the Gale score, which is the current way of risk stratifying women, you get a very strong hazard ratio of 4.7 in predicting future cancer progression. So this suggests that women that go to have a mammogram, where a tumor is found, a biopsy is found, 80% of those biopsies are benign, luckily. But perhaps we can use this algorithm to predict the risk of developing cancer in the future from those benign tumors. And so actually we've done that. So we have looked at women where a tumor is found on the mammogram and a tissue biopsy is taken. And we've used the same approach, and we can predict risk with an odds ratio of about 2.5 in future cancer. So it seems that there is a signal here that we can use to risk stratify women, which I think is good news for the world. And so we can also use predictors in the clinic. I'm going to tell you about two different stories. So one of them is looking at senescence, looking at the effect of altitude on senescence. And the reason we did that was because we know that if you live at very high altitude, then your exposure to chronic oxygen is a little bit lower. There's been a lot of ideas about how oxygen might influence the rate of aging by potentially oxidative stress. And so what we see here, this is in Ethiopia, which has the largest population of people living at high altitude. We can see that there's a very strong linear relationship between altitude, elevation, and life expectancy. So the individuals that live at higher altitudes tend to live longer, and they have less disease. And this is, I think, bad news for Denmark because we're very flat, close to the water. But we can also go into a part of Ethiopia, so the Tigray region, where we then went in and took blood samples and facial photographs of individuals in different areas to see how if we could see changes in these markers of aging. And so we have sort of two approaches, right? We have our facial photograph where we can look at predicted age, and then we also did blood smears. And when you do blood smears, you get nucleated cells, and then you can do senescence prediction on the nucleated cells. And so what we can see here is that if you live at higher altitude, you're predicted to be older. And that corresponds, I think, well with probably UV exposure. You're at higher altitude, you have more UV exposure, you probably age, your appearance of aging occurs faster. Conversely, your DNA damage predicted senescence is actually lower at higher altitudes, particularly in monocytes, both looking at ionizing radiation and doxorubicin. So this could support this idea that DNA damage could be driving some of the features of aging, and that this may be driven by, could be driven by oxidative stress. And so in the final parts of my talk, I'm just going to tell a little bit about a study we did on COPD, so chronic obstructive pulmonary disease, which is mainly caused by smoking, but is really just an accelerated aging phenotype of the lung. And so this relates to when you smoke, you induce DNA damage, and that activates an enzyme called PARP1, and then PARP1 leads to loss of NAD, and we're probably going to hear a lot about NAD at this conference. And so I've done a lot of work together with Dr. Fang up there, where we looked at how DNA damage might impact accelerated aging through this enzyme PARP1. So you can inhibit PARP1, and then you extend the lifespan of model organism, but you can also use a supplement, for example, NR, nicotinamide riboside, to increase NAD levels and then compensate for some of this loss of NAD that's maybe driven by DNA damage. And so because DNA damage is central in COPD, inflammation may be PARP-driven, we were thinking maybe we can use precursors to impact COPD. And so we did a double-blinded RCT, treated with NR or placebo, and then treated for actually a very short 6-week period and had a follow-up 12 weeks later. And we saw that COPD patients had lower NAD levels in the blood, and the amount of NAD levels actually correlates with lung function. So if you have worse lung function, your NAD levels tended to be lower. Our primary outcome measure was IL-8. We see that we get a significant reduction in this inflammatory cytokine in the sputum, so in the lung. And this also correlates then with less recruitment of neutrophils, which are involved in probably the pathogenesis of COPD. And so this is just an example of how we also use our predictor here, because you can identify cells in the sputum. You can use the senescence prediction, and we don't see any significant difference, but there's a trend at least. We also looked at DNA methylation clocks, and we see that COPD patients have increased accelerated biological age, looking at DNA methylation. We don't see any significant effect by using any of the clocks, but there's a strong significant correlation between inflammation in the sputum and, for example, whore rats. I have to hurry now. But there's actually also strong positive correlation with IR senescence. And so, perhaps NR could be a way of impacting inflammation in COPD patients. And so to sum up, aging can be quantified, and we can impact aging and disease with targeted interventions. And so I'll stop here. And thank you so much for listening. This is our funders, and